Next speaker is Dr. Jonathan King, who is a faculty member in the Division of Surgical Oncology at UCLA, and also a member of the UCLA Aggie Hirshberg Center for Pancreatic Diseases. John did his surgical residency here at UCLA. We did it together. And then he went and got trained at the University of Pittsburgh in doing robotic pancreatic surgery. When John trained at Pittsburgh, it was like the mecca for robotic pancreatic surgery. So he's incredibly well trained. John is an incredible surgeon, very, very, very technically talented, and a great doctor. So really glad he's part of our team, and he's going to talk to us today about surgical treatment of pancreatic cancer, a moving target.
All right, good morning, everyone. And I want to start by saying that it really is my privilege and a distinct honor to be able to speak today. Oh dear, this moves. This being the 19th Annual Symposium, I started coming to these maybe 15 years ago, and how far we've come. And this is a perfect correlate to kind of where treatments, surgery, everything for pancreas cancer is going. Where continued progress, however measured that may be, is the day-to-day norm. So we're going to talk about surgery for pancreas cancer, which is one of the real cornerstones of treatment for pancreas cancer, and something that really anybody with a diagnosis should be familiar with. And to start, I do not have any conflict of interest. I have a screen over here that I'm going to use. So this is me. One of my patients pointed out to me that this headshot might need to be updated, and I said, "Heavens no! Why would I ever do that? Because this is my forward-facing kind of bit. I like to keep this youthful visage out there." Anyhow, I was born and raised in Bethesda, Maryland, and I did my medical school there at my state school. Came out here for general surgery residency and overlapped some of my time with Dr. Donahue, as he mentioned, before going to the University of Pittsburgh, and did a complex surgical oncology fellowship there for 2 years before coming back to UCLA to join the faculty. And I have two main clinical focuses, foci, perhaps minimally invasive approaches to pancreatic surgery. So as Tim mentioned, we have rolled out our own program of robotic-assisted complex pancreatic surgery. We did our first Whipple here in 2016, and then also a program of treatment for disseminated intraperitoneal malignancies, what's called HIPEC. So a bit of a different region of cancer care. So here's our outline, and we're going to kind of run through a real brief history just to kind of say where we were, talk a little bit about surgery in the modern era, and then some future directions in surgery. And then I want to spend some time, and there's a webinar also from a couple years ago that we've adapted for this, but from a patient-centered perspective of what can I expect? Surgery is kind of this black box for many people, and kind of understanding some of the nuts and bolts of how that works can be helpful to not only prepare yourself, but also just to satisfy curiosities. We'll talk a little bit about recoveries from surgery, and then some things that follow surgery. So brief 10,000-foot view of where we've been, and you can really think of the nidus of pancreatic surgery really starting at the turn of the 20th century with very famous preeminent surgeon William Halsted, who actually didn't do a pancreatic surgery per se. It was removing a periambulatory tumor, so this is where the pancreas joins the intestine. But that really kind of kick-started the idea that it was feasible to operate on the pancreas. And in the early part of the 20th century, a lot of the troubleshooting in terms of how these procedures could be done was worked out. In the onset, it was always a two-stage procedure. The first mandate was to deal with what was usually a biliary obstruction. So, most commonly even today, people, we find out about these tumors because of jaundice from blockage of the bile ducts, so people turning yellow. So the first step in these olden days, if you will, was to fix that jaundice, to fix the physiologic perturbations that result from it. And then to later come back to then more definitively deal with the tumor. And so, we're talking for the first 40 years or so, people working on, well, how much of the pancreas can we remove, and how can we reconstruct it? And the takeaway from here is that these early surgeries, these early experiences were incredibly morbid, and even people experienced a lot of mortality. So you read back to some of these historical articles, and these surgeries, people didn't survive nearly to the extent that one would want or expect these days. In the early 1940s is where the namesake of the Whipple operation, Alan Whipple, was working at Memorial Sloan Kettering in New York, started to work out what we would consider to be the steps of the modern operation. Again, still usually as a two-stage operation, and again, with a lot of people not even surviving the surgery. But then you see a big blank spot in the timeline here, and things were a bit stagnant over that period of time. And then, we bring this story to UCLA, actually, and Dr. Longmire, the founding chairman of the Department of Surgery here, along with one of his partners, Dr. Traverso, then refining further and publishing on the variant of the pancreatic duodenectomy, and really kind of establishing now what we would mostly consider the modern era of pancreatic surgery. And that's characterized by drastic reductions in the risk of dying from these surgeries, to the point where now 1% to even less is considered the industry standard, if you will, compared to 40% mortality. Those are pretty stark differences, and represent a lot of historical progress that has been made. And it's on these shoulders of these giants, that people like me stand to then try to further refine the procedures and offer these to patients. So, no discussion of pancreatic cancer surgery is complete without discussion of a little bit of the anatomy, and Dr. Donahue did speak a little bit to this. But, the pancreas, do I point down here? Yes, I do. Okay. The pancreas lies in this sheltered location. In this anatomic drawing, we see that actually part of the pancreas has been taken away to be able to see some of the blood vessels. The blood vessels that go to the liver, that go to the small intestine, that go also to the spleen, are all very intimately associated with the pancreas, such that in some respects the blood vessels actually travel essentially through the gland. And so, real estate being precious in this area, you can see how a lot of these tumors have the opportunity, at least, to abut or even invade some of these major blood vessels. But there are also other neighbors, important neighbors, things like the stomach, the spleen, when we're talking about the tail of the pancreas, the bile duct. We talked about how blockage of this is what leads us to know about most of these tumors. The first part of the intestine, we call it the duodenum, and even the colon. So again, precious real estate, all this is packed into a very compact area that we're talking probably about this big. That's like the entire pancreas and all of its neighbors. If we're talking about the tumor, we're talking about an area even smaller. And so it's no wonder then that these tumors will often impact surrounding structures. I did want to go say that surgery, by the way, is, as I said before, the cornerstone of treatment for pancreas cancer. It's not for everyone, meaning that we typically need a tumor that is localized to the pancreas without spread to the other organs. And obviously there's exceptions to every rule, but this is generally speaking, what we're looking for in terms of recommending a surgery. There is also, and I intentionally put this in brackets because this has in the last 10 to 15 years become less and less of a consideration. We have to see that the tumor is not involving, in a major way at least, major blood vessels. Now that is a very big caveat, by the way, that I'll make later. Again, that is changing. But another take home from this is that surgery is complex, even in the best case scenario of there being no major blood vessel involvement. And it's something that we have to take into consideration in terms of managing that complexity and how it interacts with the complexities of other aspects of people's care, whether it be other medical conditions that an individual may have or other treatments, things like chemotherapy. An important consideration and something that we have to work carefully to mitigate is the realization that tumor does nothing to treat the tumor that has spread outside of the pancreas. And so this is the reason why when we look for people who have spread of the tumor to other organs, this is the reason why we tend to not offer surgery in that situation. That doing a complex surgery to remove only part of a tumor doesn't make logical sense. And so we have to then think about treatments for the whole body to treat tumor that has spread outside of the gland. And so that is where chemotherapy comes in, where medications circulating throughout the body are able to address tumor that has spread outside of the pancreas. But it's not black and white. Spread of tumor, chemo, non-spread of tumor, surgery. In fact, most everybody will require some form of chemotherapy, and most people in whom we're doing surgery, again, will require some, or at least have a recommendation for some chemotherapy. And multi-drug regimens, as Dr. Donahue was speaking out about, are the standard of care. So, these days in 2025, medical treatment of pancreas cancer almost always involves multi-agent chemotherapeutic regimens. And just to say that side effects are common but manageable. So as Emily was saying earlier, we are able to predict and anticipate these side effects and generally are very good at managing them. There are two main operations. Dr. Martin mentioned a third one that is infrequently, but still sometimes used. Just last week, performed a total pancreatectomy for somebody with cancer. But generally speaking, Whipple operation, distal pancreatectomy are the two main operations that we have. The Whipple operation involves, in this cartoon, you can see where the part of the pancreas having a tumor is in the head, and we remove that head of the pancreas. Part of the bile duct that actually goes through the pancreas and is often affected by the tumor, which again causes the blockage of the bile duct and jaundice. The duodenum, so this first part of the small intestine, is removed. And sometimes a part of the stomach. And that's surgeon specific. Some people do, some people don't. The gallbladder also routinely removed. So this is the Whipple operation resection. That's where the part that we take out. With that come lymph nodes that are important for staging. When we then go back to put everything back together, we have three connections to make. The first is a connection between the pancreas and the small intestine, which my highlighter is on. That is the crux of the whole reconstruction. These are difficult and finicky connections that we make, and they have a propensity to leak, and that is something that is a major known complication at times of pancreas surgery. It's the reason that routinely here at UCLA, pretty much every patient will get a drain, which is a thin rubber tube that goes and sits next to the edge of the pancreas or where we've made this connection. Because we know that about 10-12% of these will leak in some measurable way. And so that leaves 90% or more that don't leak. But we like to have that bit of safety because when these connections leak, they can mean having an infection and can mean delaying people's recovery. So by having that drain there, we actually preemptively treat the possibility of that. But most people, we take that drain out before they leave the hospital. So that's the first connection. The second connection is between the end of the bile duct that we cut in the intestine. You can see it here. And that is something that we use sutures to sew up, and so it heals very reliably. So that becomes less of a concern in terms of leakage from that connection. And then finally, we make a connection between either the stomach or the small intestine and another part of the small intestine. And this is what reestablishes the route for food to come down the esophagus and go into the intestine. And this actually, reconstruction is tried and true. It's been done for now close to 100 years, and this is what allows people to, once they've recovered from surgery, eat actually remarkably normally, maintain their weight and absorb nutrients, and it works. It's a miracle of the human body, really. And as far as how we do this operation, the traditional way is with an incision that allows us to have our hands in there and using regular surgical instruments. And more recently, and certainly something that I've taken great interest in, is ways that we can do this with small incisions. And usually that's with a robot that helps control surgical tools. The other operation is much simpler. It's called a distal pancreatectomy. It involves removing a tumor in the tail of the gland. And basically all we need to do in that situation is remove the tumor and the part of the gland that it's in. And we do routinely for cancers remove the spleen. And the reason for that is that the blood vessels that go to the spleen also have along it the lymph nodes that we need also for staging of the tumor and that prognostic information that comes along with it. So these days, pretty routinely, the spleen comes along with the pancreas. And that actually ends up being okay because the spleen is not functionally significant in adults. And outside of a few vaccines that we deliver to make sure to cover for some infections that can happen, people live normal lives without a spleen. And so that's not functionally significant. There is no reconstruction. So herein is the relative ease and simplicity of this operation compared to the Whipple operation, where we don't have these connections to make. However, this line where we divide the pancreas can still leak, and so we have various ways of dealing with that end, but we are still concerned with the possibility of leakage from the end of the gland, and for that reason, people still routinely will have a surgical drain, that little rubber tube that stays for a number of days after the operation. This being a slightly simpler operation, again, the minimally invasive techniques for doing distal pancreatectomy are actually a little bit older. People have been doing this for a little bit longer, and what I've listed here is regular laparoscopy without the robot is something that has been around for quite some time. But certainly we use the robot as well, so robotic-assisted laparoscopic, and that just offers some more tools at our disposal. And then, of course, the traditional approach of doing it with an open incision still remains an important way of doing it. So, we're talking now about surgery for pancreas cancer in the modern era, and Dr. Donahue, basically outlined some of the things that we're moving towards, and again, right around the time of my completing my residency, is where a lot of this really started to gain steam, and where we more routinely began employing techniques where removal of some of these major blood vessels, the ones going to the liver and small intestine, began to be worked out. And so what this cartoon drawing is showing is that, here's the end of the pancreas. This was a Whipple procedure, so the head of the pancreas, which would have been overlying this, has been removed, and there was this segment of the vein that was invaded by the tumor. And as it turns out, this can be divided here, and then sometimes the ends will actually meet each other. If there's a longer segment that is involved, we can actually make a graft that we can sew in and replace that segment of the vein. Sometimes it's a little simpler in that we don't have to actually remove an entire segment of the vein. We can just take a patch of it out and just like patching a tire, sew in something that kind of replaces that little bit of the vein that is missing. We also, this picture is not showing it, but where this is the artery going to the liver. So this was a vein going to the liver. Well, the artery going to the liver, if the tumor is invading that, can be removed and can be reconnected. That's a little bit more work, a little less frequently done, but definitely something that's feasible. And then this artery here, the one coming down this way, is what goes to the small intestine. Very, very important artery and something that none of us can live without. And as it turns out, it also is very close to the pancreas and very close to many tumors that arise in the pancreas. And when that's involved, that in selected cases can also be removed. I would say each one of these, I've intentionally put them in the order that I have in terms of this vein, the hepatic artery, and now the mesenteric artery, represent increasing levels of complexity and difficulty and potential complications. So we, in that order, tend to employ these techniques to remove tumors of the pancreas. But by doing so, we expand the indications for surgery. These are no-go zones in terms of all these vascular resections and reconstructions back as recently as when I was, again, completing residency. So it's really been in the last 10 to 15 years that this is now the routine care for people. And one point that I make here in my bolded points is that almost always, if there's going to be certainly a plan for removal of any of these blood vessels, we precede surgery with chemotherapy. And this is because, well, many reasons. One is that sometimes we can actually see the tumor shrink away from the blood vessels in a way that obviates the need for this more complex work. Other times, we're looking to administer the chemotherapy beforehand in a time when people are, relatively speaking, strong, fit, and not dealing with recovery from a major surgery. So as we increase the complexity of the surgery, there is some increase in the likelihood of delays to recovery, even complications. And that can mean delays to chemotherapy. So rather than risk having chemotherapy delayed by surgical recovery, we flip the script and give the chemotherapy in these cases routinely beforehand, at least some of it. Not always all of it, but at least some of it will generally go before the surgery. As I mentioned, that the whole idea of this is that we actually expand surgical candidacy to a greater number of people because we know that surgery is, again, one of the cornerstones of treatment and arguably the most effective treatment for pancreatic cancer. So we want to give as many people as possible the opportunity for surgery. As far as the oncologic aspects, one of the reasons that this was oftentimes not done in the kind of before the modern era is the thought that we weren't helping people, that removing these blood vessels was something that represented a different kind of stage of disease. And now we recognize that not so much. With doing these surgeries safely, we actually are able to offer the oncologic benefits to people even with these complex vascular resections. All right, so future directions. So as I mentioned just briefly, sequencing of therapies. This is something that's already ongoing. It used to be knee-jerk. Everybody with a resectable pancreatic cancer, surgery first. Well, people have rethought that idea, and there's a growing movement to sequence even in resectable pancreatic cancers with chemotherapy first. And so that's something that is thought about regularly now. We don't always do it, and still with people with resectable lesions, we do tend to still go to surgery more often than initially with chemotherapy. And then, of course, immunotherapy being part of the systemic treatment algorithm, is increasingly used as well. So there will be, going forward, further refining of the indications and limitations of major blood vessel resection. These are relatively new techniques in terms of the grand scope of surgical management of pancreatic cancer, and will further refine those indications and limitations, as I say. Future directions, expanding capabilities of minimally invasive approaches. We're going to talk a little bit about this in just a moment, but robotic surgery, we actually do these vascular resections to some extent. Not all of them, but some of them, and more in the future, I would predict. And then this last one is, our looking forward longer down the road. In that, when is surgery for metastatic disease appropriate? This is a question. I'm not providing answers. I've bolded that currently metastatic disease is a contraindication for surgery in a vast majority of cases. But similar to the colorectal cancer world, where people with spread of their tumors to the liver will routinely have resection of parts of the liver, I imagine a future where that will be possible. And where Dr. Donahue was talking about all these improved treatments, that's the difference between colon cancer and pancreas cancer, if you ask me, is that the other treatments are what then open the door for more aggressive surgical approaches that are intended to cure. And we've seen that not only in colon cancer, but in the GYN-onc world, things like ovarian cancer, where their treatments are better, we have the opportunity to apply surgery to a greater number of people. So that's something that I would predict is coming down the pike. Preparing for pancreas surgery, I am not going to step on the toes, I promised, of Shelby Yacuzio, as our clinical dietitian, is going to speak next. I'll just leave it at this. I want you strong coming into surgery so that you're strong coming out of surgery. That is where the rubber hits the road. And so these are very critically important aspects. What happens surgery day? We're going to run through this pretty quickly because actually I'm already in the red I see here. So very quickly, you come into the Reagan Hospital. We do all these surgeries at the Reagan Hospital. Admissions on the first floor where they get you up to the second floor. We early in the morning. The nursing team will meet you, they interview you, get your vital signs, place an IV catheter, the anesthesia team interviews you, and you introduce yourself to them. The surgical team will come by and say hello, and a whole fleet of people will be coming by. Who are all these people, and what the heck are they doing? Well, nursing, you have different nurses, both for the pre-treatment area as well as the OR nurse, where they're going to be asking questions. Many of these questions get repeated multiple times through the day, by the way, where they're asking you, what are you having done today? That's a common. 3 different people, at least, will ask you that question. And it's not because we don't know. It's because we're making sure that you're aware. Surgery preparation, we communicate with the family, the surgical technician, oftentimes you'll see as well. The anesthesiology, we actually have 2 anesthesia teams typically, one to place the epidural catheter, which I'll mention in just a second, and then also the actual anesthesiologist who will be administering the anesthetic for the procedure. And obviously the surgery team is performing the surgery and your postoperative recovery. So epidural catheters are fairly routinely used, certainly for my patients. I routinely recommend these. It's a long, thin catheter that actually goes in the space right around the spine where actually low doses of local anesthetic and a narcotic can be delivered. And it helps speed people's recovery in general. And so it's very effective in the pain control and is something that we rely on for the first really 5 to up to 7 days after the operation while we're getting you, through those early steps of recovery. It's not mandatory, and so some people defer this, and that's fine, and we have other ways to manage pain when that's the case. We talked a bit of the different approaches, and so the traditional open approach, involving an incision, usually in the upper midline, kind of between the breastbone and the umbilicus, versus the robotic approach, where we have lots of small little incisions and one that has to be big enough to get the piece out. And this is the robot, the operating robot, and you see the patient being over here. There's somebody at the bedside that is assisting, and then the surgeon sitting at the console controlling laparoscopic instruments that have wrists. And this is what enables us to do a lot of things like sewing much easier than with traditional laparoscopic tools. So this is what it looks like. So this is where we've placed all these are what we call ports or trocars, and these are what allow us to introduce instruments into the abdomen. and do the work. And for the squeamish, you might avert your eyes just a little bit. Not that there's blood, so much here, but this is video of an actual surgery. And so this is a little bit sped up, but this is one of the critical steps of the operation where below this instrument, we're looking at that main vein that goes into the liver. And what we do is we actually make a tunnel between the pancreas, which is over top, and that vein. And this is one of the key steps of the operation. And these instruments, the robotic ones being kind of on the top here, this little hook-shaped instrument, and the grasper here, we're able to dissect our way up underneath the pancreas and along that vein to the point where we've made a little tunnel there. So that's one of the key steps of the operation. And then when we come back to reconstruct things, put things back together, we have here needle drivers and a needle, and you'll see how we're able to manipulate this needle in ways very similar to, if not identical to how we would do it with regular instruments. And so this is the value of the robot in making it possible to do these operations. This is us connecting the pancreas to the intestine there. And so here's what to expect. So hospitalization, somewhere between 4 to 7 days is kind of the big part of the bell curve. And it kind of plays out most often like this, where day 1 we'll have you out of bed and broth and jello on day 2, and we usually remove the drain when it's not showing evidence of a leak by day 3 or 4, and introducing solid food. And then, right before, kind of getting ready to go home is when we remove the epidural, we transition to pain medications by mouth, and prepare for discharge, as I say. And then home recovery, this is just the tip of the iceberg in terms of the recovery curve. So, I'm quick to point out that, people going home, you're not going to be, recovered at that point. And so the recovery continues, and really up to 6 to 12 weeks for full recovery is what we can expect. And somewhere in there, seeing the oncologists and starting chemotherapy actually is usually within that window. So we expect things like fatigue, poor appetite. That's normal for after surgery, and it's something that recovers slowly after surgery. And so some people will have a surgical drain to manage, which sometimes goes home with you, but most often, as I said, not. What not to expect after surgery, but can happen. So complex surgery, there can be some delays to recovery. Pancreatic fistula is number 1. And so that's where there's a leak from where we made our connection between the pancreas and the intestine, and can sometimes require treatment. Some people actually will get kind of sick from it, need antibiotics, and sometimes another procedure. Something else that we always consider is the stomach sometimes doesn't empty the way it should after surgery, and this happens in about 8 to 10% of people on some level, and sometimes requires some treatment. Infections can happen, sometimes requiring antibiotics. Things like blood clots, bleeding, these are all things that are possible, but thankfully happen in a small minority of patients. So most people experience uncomplicated recovery. And then this is where I was saying, well, what happens afterwards? Well, then there's chemotherapy often, if it wasn't done before surgery. And then you embark on surveillance and, making sure that the tumor hasn't recurred. And so this is a standard part of post-treatment care, in that, we actually actively look for evidence of recurrence. And this takes the form of usually CAT scans or MRIs, as well as that tumor marker that's periodically checked. And that is it. I think, again, a lot of the take-homes I make, I put in bold, and I think, understanding that, surgery is anxiety-provoking, especially major surgery, but it's manageable. And the recovery from surgery is a major undertaking as well, but doable. And, we're basically here to help you. And this is all stuff that people do get through, and I think that's where I would like to end it. Couple questions? Okay, go ahead.
I have a quick question. I had the distal pancreatectomy that worked for about, and chemotherapy, which worked for about 2.5 years. And then I had a metastases to the liver. And in your presentation, you were talking about some of the newer interventions were to maybe remove the connection between the pancreas that's being removed and the liver. And I don't know, Dr. Tim, at the time I had my distal pancreatectomy, was that a possibility of removing that connection? We took out 40% of the pancreas, the spleen, 8 lymph nodes, but was there anything about, at that time available in 2020, about taking the connection away from the liver?
So Dr. Donahue, certainly yes, was doing that, but probably wasn't necessary if it wasn't done. If your tumor came out without taking out that vein, then there would be no reason to take out that vein.
Even though there was an eventual metastases in that direction?
Correct. It's only done if the tumor is wrapped around the vein in a way that we can't separate it at the time of surgery. And so, no, it's not a way to prevent future metastasis. We don't, other than chemotherapy, there are no technical ways that we have, in the operating room or with other procedures. There are no technical ways that we have to prevent spread of a tumor, from a localized process into other organs.
Okay, I went home with the tube in and the drain thing. I made a little pocket to hide it so it wasn't visible. The grossest thing was the day that I went for it to be pulled out, and it was like 6 inches of tube and 6 inches of what looked like a gardener drip hose kind of thing, a big thing. And I said to my husband, catch it on video. I want to see this. It was like a snake being removed. Okay, that's it.
Sometimes joke we tie it to the doorknob. Just kidding. Go ahead.
Hello, thank you for your presentation. I really appreciate it. My name is Ashley Baylor, and I wanted to know, with surgeries, if you've had to remove any lymph nodes, have you ever come across patients who are impacted by lymphedema in any way?
So lymphedema is something that happens in breast cancer, melanoma patients, where we're removing lymph nodes from a place like the armpit, and where you have an extremity then that is draining lymph fluid. You can think of lymph fluid like the fluid inside a blister back towards the body. And that can be a big problem. People's arms get swollen, it's very uncomfortable, it has other issues. So that thankfully is not an issue in GI surgery, where we remove a lot of lymph nodes actually, but there's ways for the lymph fluid to get back to where it needs to be. And so no, thankfully that is not an issue that we encounter.
Okay, thank you.
Go ahead.
Yeah, I think last year they had an observation they added to a list or something about pancreatic cysts turning cancerous like a year later. So I had a question. If you had a cyst that's side branch but a little bit communicating with the main duct, and you wanted to do like a minimalist approach, can you go in there and inject like a high concentration of a chemotherapy drug or burn it out or something like that if you want to do that?
So there are some techniques that people are looking at in terms of cysts that we worry about might form cancer at a later date, ablating them with sometimes endoscopic, meaning gastroenterologists going in through the mouth and accessing these things. The most often actually management of cysts in the pancreas is observation. So talk about a minimalist approach. We actually infrequently do surgery on many cysts. Because we recognize that it's okay to observe them, and we have to keep an eye on them because they can change. But many of these are ones that we can just observe over time. For the ones that require surgery, it's usually because we're concerned about a cancer, and in that case, we're usually employing surgery to remove that part, and can be a way to actually prevent a cancer in some people. Yeah, go ahead.
Dr. King, my name is Stephen Hirsch, born and raised in Pittsburgh. Go Steelers.
All right.
When you make a determination that a patient is non-resectable, do you ever team together or confer together with interventional radiologists to discuss the nanoknife procedure in conjunction with the possibility of surgery?
Yeah, so even before that, judgment has been made, that's when Dr. Donahue was talking, about the multidisciplinary team, we're all, from the outset, whether you know it or not, involved in those decision processes with, on Tuesday mornings before our clinic, a multidisciplinary clinic where we're all sitting together and we're offering, our thoughts on how to best manage, this particular individual. So that includes surgery, chemotherapy, as well as radiation. And so, we're all hand in hand, in terms of, deciding. Now, it is true that the surgeons and the medical oncologists are typically the ones that are taking the ball and running with it, as to throw it back to the Steelers analogy. And the radiation oncologists are less commonly involved just because their treatments aren't indicated in as many individuals and have somewhat, limited, kind of applicability.
Thank you.
Mm-hmm. So I think in the interest
Great.
of time, I got to
Yeah.
step outside. Yeah.
Thank you, John. The Steelers do run the football too much. It makes their style kind of boring to watch. But thanks so much, John. Next up is,
I just had one question in regards to Whipple attacks. I don't know if you've heard anything about Whipple attacks. I, am really blessed. I'm a almost 12-year pancreatic cancer survivor, post-Whipple. A stage, considered would be 2B, but I have, periodically Whipple attacks. And I've had scans and, they say that it could be scar tissue. Is there anything that you can, that you came up with, any solutions or, things that we can address Whipple attacks?
yeah, I'm sure many of you in this room know about these so-called Whipple attacks, which are just episodic, severe pain episodes that last on the order, fortunately, of just a couple of seconds, up to 30 seconds or something. Never know when they're going to hit. They happen with various frequency. I've spoken to many others of you in this room on Whipple attacks. I've heard there's an online support group called the Whipple Warriors, where this is a frequent subject of chat room discussions. No one really knows what causes them. It's probably just the reconfiguration of your intestines in your abdomen, maybe some transient obstructive thing that resolves itself. They're very annoying. They're very debilitating. They just, they're, I guess I could call them disruptive. There's nothing to do about them other than for me to reassure you that they're totally benign. It doesn't mean that there's something bad going on. They can't progress to anything more serious. They're probably a result of reconfiguration of the intestines. And
I mean, is there not any way that laparoscopically they can go back in and see if there's some kind of a problem?
no,
or
it's
is that
not
gonna
an
create
it's
more
not an
of a
obstructive
risk?
thing. I think it's just a transient kind of obstructive-like thing. Symptoms are similar to what it feels like to have a bowel obstruction. And so I would say if these attacks are happening more frequently or they're lasting for longer than a couple of seconds, then that would be something that would need to be investigated to see if you're developing some scar tissue or adhesions that are causing a bowel obstruction. But Whipple attacks are nothing that can be done to change.